My name is Dara Curran, and I am a manager here at Life with Cancer, and really excited to be able to introduce Dr. Kogan tonight. Appreciate him coming across the river from DC to be on site here at Life with Cancer for those that come in person, and then welcome everyone who joined us virtually tonight. So just to introduce Dr. Kogan, he's a medical director at GW Center for Integrative Medicine and the assistant professor at George Washington University School of Medicine and Health Sciences. He's an integrative medicine fellowship director, primary care internal medicine, integrative geriatrics, functional medicine, and an integrative palliative care physician. He's a leader in the newly established field of integrative geriatrics. He's the chief editor of the first definitive textbook of the field entitled Integrative Geriatric Medicine, published by Oxford University Press as part of Andrew Weil Integrative Medicine Library Series, and is a frequent speaker at a variety of international conferences on the topics of integrative medicine, geriatrics, healthy aging and geriatrics, as well as neurodegenerative diseases and use of medical cannabis, which is what we're talking about tonight. He's published in both integrative and geriatric topics in leading US-based journals. All right, I will let him continue introducing himself.
Okay, so we have a couple of housekeeping issues. Everybody, please mute yourself. In fact, Dara, you should be able to mute everybody automatically. Sure. You cannot. So set it up so that nobody can unmute. So you allow it. Well, hi everybody. And as I said, don't worry, your name's not going to be seen. We're going to jump right in. I'm very appreciative that you're here. One thing is we need to make sure. I think, Dara, I think you should click that just to make. I don't think they can see it, but just in case you see that, got it. You tell me that. I think that's just what yours. Okay. It's not okay. So I have a couple of disclosures. Of course, I will be presenting my book here, or from my book. Rather quite a bit. So, and obviously I collect royalties from the books. I do have to disclose that. I'm also an advisor for a number of different companies, including for-profits and non-for-profits. As it relates to cannabis, I'm also an advisor for the National Cancer Institute on complementary and alternative therapies, and there are also for that work as well. In fact, in that format, I reviewed a number of cannabis-related articles to advise the general public as on some treatments related to cancer. So I started recommending cannabis back when DC approved it in 2010. So started recommending in 2011 when we set up the system. We're seeing about 5,000 to 6,000 patients per year, and about 20% of them with cancer, and about half of them without cancer.
Can you project a little more?
Yes. Is that better? Can you guys hear me better? We could set up the mic, but there will potentially be a lot of background noise, but we can try it. So why don't we try it? Now let's see what happens. How about that? Is it better? Can somebody tell us whether the sound got better or not?
Yes,
it's better when you hold it closer together to your mouth.
Better for you guys. I am very appreciative of participation. We got 40 some people signed up and 34 people here. That's really good. Actually, 35. So cannabis and oncology. Believe it or not, it's one of those topics that oncologists do understand that a lot of people are using cannabis, but they don't really understand the actual percentage. So this is relatively old paper in the cannabis world. 2018 is considered patient. We usually operate in the field of cannabis bi-monthly because the field is so rapidly changing. But in 2018, about 43% of all cancer patients in Canada used it, and it goes up by about 2 to 3% every year. So we basically have statistics that at least about half of all the patients as of 2020 using some form of cannabis of all the patients with cancer on average. So it's not a surprising number, by the way, given the amount of evidence that I'm about to show. And what's interesting is that when there's legalization that occurs in a particular state, there's a massive uptick in the utilization, which again you would expect. But what's also interesting is that despite that interest, oncologists are seemingly always behind with not only recommending cannabis cards for patients, but also just even knowing what are the resources at stake. Again, none of this is surprising because if you think about this in medical schools, physicians are really not learning about this at all, nor are they learning in residencies and fellowships. So the big problem here is simply lack of education to the healthcare providers, and often that generates the issue that the patients who are interested in using medical cannabis, they end up going to the providers that are not physicians. Sometimes they're not even licensed healthcare providers. It could be what's called the cannabis coaches. We'll talk about that some. Okay, so before we actually jump right into the clinical use, you do need to understand some basics. I could ask all of you here on Zoom whether or not you understand what's on this slide. Now, this is a very technical slide. I don't expect you to understand much, but I want you to particularly pay attention to the highlighted 3 words: the ligands, the receptors, and the enzymes. So the way this works goes like this. Our system makes a lot of cannabis. So we make equivalent of any, well, actually it's kind of hard to express, but we make a lot of it and we make it on demand. There are multiple different cannabis-like molecules. So anandamide is the most common one. Literary translation means bliss. Yes, we do make our own bliss, believe it or not. And it turns out that that bliss is much more cannabis-related and not opioid-related. In fact, opioid, endogenous opioids will make us blissful, say endogenous cannabis. Then there are receptors to which this endocannabinoids bind. And then there's an enzyme that has to remove the endocannabinoids from the system when the effect is finished. So the enzymes that degrade, but there are also enzymes that make the active ligands. In kind of a more graphic way of thinking about it, it goes like this. So you have a transmitter, some kind of a cannabinoid, that goes to the receptor. It generates the signal. The signal gets passed around. And then after that signaling state is finished, you break down the molecule because it's no longer needed. So, and the cannabinoids are continuously produced in this cycle on demand. Some of them are produced in the central nervous system in case of anandamide. Some of them, in case of 2-HG, produced more on the peripheral tissues. But what's really essential is that the receptors, and you see that in the next slide, are in every cell of our body. There's only one place where receptors are not present. I'm not going to say more about it, but it's going to come very important when we finish the talk, because there will be a surprise at the end, and I hope you'll stay for that surprise. But the surprise is linked to the receptors. So if you want to Google on something, you could try it, but we don't know exactly what it asks. Because if I do, then we Google, then it's not there. Okay, so then it doesn't kind of matter whether the cannabinoid comes from us, so we make it, or it comes from the plant, particularly the plant, of course, medical cannabis. Of important significance is cannabis is not the only plant that produces cannabinoids. There are many others that do. We just don't really talk about them much in clinical format because they produce either very little, or they produce molecules that are considered to be minor cannabinoids, but we'll touch on that. So in another way, you can think of this whole system of the receptor and the ligand as a key and lock mechanism. So you have a key that goes into the lock, opens that lock, triggers some kind of a response, so the door opens for some body function. And then when you finish, you close the door and you throw out the lock, and then you need a new lock. So like this kind of a constantly changing system. As I said, receptors present in every single cell of the body. It becomes very important to know that the CD2 receptors are very heavily present inside the immune system. So that is very critically related to the way our system fights the cancer. In fact, the anti-malignancy effects of endocannabinoid system have been documented for many decades. And of course, we're going to talk about can you use cannabis as a cancer cure and what is the evidence course, we're going to discuss this, but the basic understanding of how that happens has been worked out. Now, I don't expect you to understand any of the details of the slides. The only reason I'm pointing this out is to think of it this way. Endogenous cannabinoids or exogenous cannabinoids will upregulate the immune system to cause a couple of different things. Those are the listed here. They can inhibit the inflammatory response. They can inhibit propagation of the angiogenesis, which is very important when you're talking about metastasis. Metastasis have to have a blood supply. Angiogenesis is the process by which new blood vessels are generated. It's also critical that
I'm wondering if I can mute this and you use your laptop because they're saying it's echoey.
all right.
Okay, is that better? And I'm gonna,
Much better. Yes, thank you.
Way better. Okay, all right, great.
Thank you.
Very good. Thank you, everybody.
Thank you.
It's a team effort, right? Yep. All right.
Could everybody please
Okay,
mute?
so so this becomes very important when we talk about all kinds of steps in the cancer care. I will not come back to this slide, but I'm keeping it on a screen for a few minutes because it's kind of important, because a lot of the basic understanding of how exogenous cannabis works and how we apply it in a clinical care comes back to this slide. It's also essential to understand that while we have a lot of evidence that cannabis can kill cancer cells, we have very little evidence in an actual human tissues. But there's a tremendous interest because of this particular picture, because we know that there are many pathways in which cannabis can kill the cancer or slow down its growth, both. Okay, so I told you about endogenous cannabinoids. So we have 2-AG, we have anandamide, we have PEA, we have a whole bunch of others. But exogenous cannabinoids, you probably hear them by those two large names. The one is called THC, or tetrahydrocannabinol, particularly the one what we call is delta-9. I'm not going to cover in this lecture delta-8, delta-10, and all of those other psychotoxic cannabinoids. It's beyond today. But THC has a lot of non-psychotoxic effects. So it's anti-inflammatory, it's neuroprotective. We use a lot its anti-nausea and analgesic properties, of course, in cancer, and that's where we will be talking a bit about. And then, of course, there's also CBD. Now, the CBD can be produced both from cannabis and from hemp. And you should ask me immediately, well, what's the difference between the cannabis and the hemp? Zero, not at all. It's the same exact plant. It's not any different. It's a human mind that created this separation. In fact, I'll tell you bigger information that you may have not even known. We'll talk about different cannabis plants, cannabis sativa, cannabis indica, cannabis radialis, hemp, throw all that out. It's just one plant, cannabis sativa. There's nothing else. Everything out there is, and there's about 22,000 of them. They're variants. So they're not even the different strains. They're identical plants, but they're variants. So they're different types of plants and they produce different buds and they look sometimes very different, but it's the same genetic originator. Why is it important? Because cannabis is like virus, highly mutating. There's still people who are not muting for some reason. Okay. It's highly mutating organism. It can mutate very rapidly, which is what we use in clinical practice, which is what industry is heavily relying on, constantly making new variants, constantly creating new products, etc. But again, it's the same plant. The difference is when we're talking about the hemp is that there's very little THC inside the plant. So it's grown for particularly either CBD or for something like an industrial hemp for its textile. For nowadays, there are even houses being built out of hemp, and turns out it's a wonderful construction material. I go to these cannabis conferences and I learn stuff that I was like, oh my God, it's they make the bricks out of hemp, and in the way it's produced, it's very fire retardant. Who would have figured, right? So you can make a lot of things out of hemp. Of course, we can drink hemp milk. Okay, we can eat hemp seeds, hemp protein. I mean, there's all these things, right? So they're totally not going to make you high ever, because those variants are selected to contain primarily CBD or even nothing, just an actual fiber, etc., and a protein. So CBD has a lot more documented properties that are clinically relevant. So it's neuroprotectives, and it's anti-anxiety, and it's antidepressant, et cetera, et cetera. And it does have some really strong anti-cancer impacts, and we'll talk about that. What's really more important in terms of clinical practice is that the CBD tends to mitigate some side effects of THC. So THC has a lot of side effects. We'll talk about that. There's a slide showing not just the side effects, but how you can deal with them. And CBD can remove some of those side effects or prevent them altogether. So most of the time when we're talking about clinical practice, when we use THC for symptom management, we will combine it with some CBD, okay? I'm gonna pause here for a second, leave this slide on, but I will tell you that there's a lots and lots more cannabinoids, and I'm gonna just list some of them, but we're not gonna cover them because there's no time. There's CBDA, THCA, so those are the acidic forms, which are really critical. They seem to be even more potent anti-inflammatory, and THCA is even more potent, potentially anti-emetic and anti-anxiety. And neither of those make people high. Acidic forms of what's actually present in the plant before it gets processed. So in order to make THC and CBD, the plant has to be harvested, and then you need to either heat it up or do some other chemical extraction to produce CBD and THC. So you convert acidic forms to non-acidic forms. There's also a long list of other cannabinoids, and I'm again going to mention just a few. CBG is a very important cannabinoid. It's very relaxing or very sleep-inducing. It's also very good for neuropathic pain. And in contrast to CBD, you don't need to take a lot of it. In order for CBD to control pain or help with sleep or anxiety, you sometimes need to take hundreds of milligrams per day. There's nothing wrong with that except the cost. And it ends up being very important. And then there's this theoretical concern of having interaction with a whole bunch of drugs, because it's a potent CYP450 3A1 inhibitor. That means that it affects the liver in such a way that metabolism of certain medication changes, and that could be problematic. Now, it's a theoretical problem. We're not seeing a lot of that in the clinical practice. A few years ago, there was a concern that we're going to see a lot of interactions, but we're not really seeing that. Important point is CBD is heavily now used for seizures, particularly in pediatric population, and in 2018 or 19, FDA approved Epidiolex, which is a pure CBD drug, and we're not seeing interactions with Epidiolex, although there are really high doses of that medication given to kids. So let's move on. And then there's this whole set of what's called the terpenes and flavonoids. So those are the molecules of a color and a taste, and they're critically important. They form what's called an entourage effect. What is entourage effect? Entourage effect is when you take the active cannabinoids like THC and CBD, you combine them with this minor constituents, they're present in a very small amount, and then they can actually potentiate or negate the effect of those molecules. And we use this in clinical practice a lot, and I will talk about this in some detail because it's actually very important. When you're getting the different variants of cannabis to try, you have to know what's in them, because that's what's going to create most therapeutic effect, not just the THC and CBD. In fact, we believe strongly nowadays there's so much evidence that basically points out to one critical aspect. If you get a pure isolate, you just bought a gummy that has just THC, you can at least double impact, if not triple, by adding this whole extract processes and adding all these micro elements in there. And that's what's called entourage. Entourage is potentiating of the main effect of a main constituents by minor constituents. That's how nature operates. Drug-wise, we don't have that. We can't take a medication and say, well, why don't you take something else with this medication to potentiate it? Doesn't work that way, but nature does. Nature puts different compounds together, and that's what often creates a much higher efficacy with much lower dose. That's why I'm a very strong proponent of one idea. Don't worry about pharmaceutical industry taking cannabis over, because they can't. There is no mechanism on how to do this on a level of making it pure drugs. So they will try to continue to do that, and that's fine. Epidiolex is a great example, but they will not replace this entourage effect that can only be produced by the whole plant extracts. So beta-carotene is very important. Good data on decreasing toxicity of certain chemotherapy, increasing chemosensitivity, so great to combine with certain chemo. And it also decreases liver cancer, again, in combination with other medications. So we'll make sure you have access to the recording on the slides. You can always come back here. So humulin, increased reactive oxygen species for cytotoxic effects, inhibits hepatocellular cancer, and it enhances also some medications. So, and by the way, beta-carotene is also great to potentiate anti-pain effect. So we often look for variants with it when patient has pain. By the way, I forgot to do 2 acknowledgements. So one is Dr. Leslie Mendoza Temple, sometimes we joke, my work wife and my good friend. So she's at the University of North Shore at Chicago, and we've been doing a lot of educational work together. So this are actually her slides, just want to be clear. And also Donald Abrams, who's been my kind of a main mentor here. He's a kind of a grandfather of this whole field. He designed and implemented first randomized controlled trial on using medical cannabis for HIV quality of life with AIDS back in the early 90s. He's just retired. So humulin we talked about. Now limonene, of course, you all know. And by the way, all of this smells, so you can actually, we all know what humulin is, right? We all know the smells, so the limonene is a lemon, right? That's the citrusy smell. So again, it does very specific, it boosts apoptosis. It appears to be boosting apoptosis of almost every known cancer cells. And as you can also see, it actually is regulating down, not just induces apoptosis, but it also regulates down the growth of certain cancers as well. So again, what we don't know, for example, this is all in petri dishes. What we can tell you is this. Okay, if you take 1 milligram of limonene, then this is what's going to happen inside your body to your cancer cells. Nobody knows that. There's way too many research gaps. And so what I'm presenting is mostly based in kind of an either small animal studies. And when there is small human study, then I will point it out. But again, what's not clear here is how would you apply it? Are you going to combine it with other, and when they look at isolates, like they would just give a limonene and say, this is what we're seeing. You don't know how that translates to clinical practice. But there is some data, I'll show you. Pinene, everybody knows, of course, you walk into the pine forest and you smell, that's pinene. And so believe it or not, that nature walks, and some of this importance, how we were told, go out in nature and smell flowers and all that, turns out that there's an actual biochemical impacts of that. Because when that happens, you inhaling these molecules, you inhaling pinene, and it actually enhances some of the anti-cancer protective mechanism. It does a lot of other things too. Pinene seems to be quite good for brain. It actually stimulates cognitive function. There's a good data on being considered that as one of the treatments for cognitive decline. Okay, so I'm gonna now switch to the amount of evidence, that certain evidence we have specifically for clinical application in cancer. Some of these studies are large, like this one, we're talking about 500 plus patients. Some of them are small. We'll talk about all that. So this is one particular study that's showing if you taking this drug, oxaliplatin, which is very often induces peripheral neuropathy, terrible condition, burning and kind of, burning pain is the best, or numbness really, pain or numbness of our fingers and toes, and it can ascend or descend, so it can go up or down and come up even further, up to the elbows and even the full arms and all legs. And it's actually very hard to treat. And the only medications we have for these conditions tend to be pretty toxic. They tend to cause a lot of cognitive dysfunction, sleepiness, lethargy, and even in the bad case scenario, delirium. And so we don't really have good tool to prevent, except here's the study showing that actually patients who were using cannabis, and in Israel, cannabis is administered any patient with cancer in Israel have access to cannabis. It's a nationally approved. Every oncologist has right to recommend it. And something like way more than 50% of oncology patients in Israel use cannabis. And they have a lot of data because they started doing this decades ago. So they've accumulated a lot more clinical data compared to US. And so there's a steady evidence saying that, yes, you actually have a purely disease modifying process here. So you're preventing having the peripheral neuropathy. And by the way, we have the way we use it in our clinic is very complicated. We actually use a high dose CBD in combination with low dose THC. I can't fully support that. This data basically said they were using anything, whatever the patients were using. They didn't even assess exactly what kind of THC CBD they were using. But nonetheless, what we think is that more CBD, less THC for prevention of neuropathy is the way to go. So can you actually use cannabis as a cancer treatment? So lots of hype, some really clear articles, like this is a Cancers journal. This is a very good journal, MDPI. It's a system that's very highly ranking journal. Basically, there are review articles and very deep scientific explorations that saying very promising. Why? Well, because as I pointed back, there are clear mechanisms how cannabinoids can actually either completely kill off cancer cells or at least inhibit their growth. So, but it's kind of a carriage in front of a horse here. Because if you actually go out there and you look on internet, what's happening, so this one article, just some random usahealth24.com generated 4 million engagements, and Cancer Institute finally admits marijuana kills cancer. Of course, they didn't admit anything. It's just that, so there's a lot of interest, or here, mom who took illegal cannabis oil to battle given the all clear and she's alive. So, you know, it's very hard to separate truth from sort of secondary gains. As Donald Abrams jokes, if cannabis would have killed cancer, all of my patients by a long far would be live forever since they're all on. So, you know, but there is still something here, and I will show you some hints right now, and we're also going to show you some of the real cases. And so it's not a fully dead topic at all. In fact, it's probably one of the hottest research topics in oncology, to my understanding at the moment, because how much we understand of our endogenous cannabis system, and the cannabinoid system regulating all the cancers or preventing all the cancers. So that's just points out to that. So we know clearly that these cancers are directly inhibited by the cannabis. The glioma and glioblastoma now have an actual randomized control data, which I'm about to show you. It's very, very small, but it's very helpful. The other cancers much less, but this is what we're going to review. So glioblastoma and CBD, look at the number of patients, it's only 9. So that's all we have, but that's a start. Very high dose. Problem with taking so much CBD is not side effects, it's your wallet. Because currently Epidiolex is not approved by any insurance for the cancer, for any cancer, or for any non-seizure indication. And if you take 400 milligrams of CBD from a high quality hemp producer, you'll be spending $500 a month easily, hopefully less, but it's not cheap. The CBD at high doses is quite expensive. At low doses, if you're just controlling your anxiety or preventing neuropathy with something like 30 milligrams twice a day, you'll be spending $60, $80. It'll be a lot less. So that makes it very you know, for now at least. But this was a pretty good result. Again, small study. What will it translate to the bigger result in the future? We have to see. So this is another, now this is different. This study was really not a controlled study. So it's a little hard to say, but they just survived a lot longer than anybody predicted. But this was controlled study. So basically this was nabiximol. With nabiximol, we don't have an access to this. It's something called Sativex. So it's 1-to-1 THC plus CBD. And it was combined with one of the brain cancer treatments. And there was a pretty significant improvement in survival when compared to placebo. Nabiximol or Sativex is a spray. So it's this alcohol-based isolate. So it's not a full extract. And it's 1-to-1 CBD to THC. And they were taking a relatively small dose. They were taking something like 15 milligrams per day total of THC and 15 milligrams of CBD. It's a very, very small amount. So if that's indeed gets kind of confirmed with a bigger study, then it's way forward. Now you should ask me, well, so Sativex is a drug. It's an actually approved drug in most of the Europe and in parts of South America and North America, in Canada, but we don't have it. It's not approved in US for anything. There was a study conducted in the mid-2010s in US looking for use of Sativex for chronic pain and cancer patients. And unfortunately, it did not generate positive result. And based on that, the Sativex is currently not considered for approval by FDA in US. So in essence, if you want to try something like this, your choice is going to be only one. You're going to have to get a medical cannabis card and then obtain similar 1-to-1 ratio product from any dispensary. And this would be a great topic for questions. So I'll hold that off and I'll be able to answer the questions. How do you actually get this stuff? And what are the practicalities of this? And how are you guided by that? So we'll come back to that. So then there is unfortunately no human trials for breast cancer, but personally, I recommend to every single breast cancer patient in my practice, unless they're taking immune suppressants, which will immune modulators, to use topical right over. If the tumor is localized, we give most of the breast cancer patients topical products to put right on the tumor. There's very limited systemic absorption from it. Do we do something good in the long run? We don't know, but there's really no side effects to do that. Very easy. And again, it works in the mouse studies and in the tubes. Lung and cancer works in the tube. One case report, need more studies. Again, will all of that translate to something? We don't know. Colon cancer. So there are no human trials, but there are lots of cases. And I will show you a case from my practice in a couple of minutes. So definitely works in the tubes and in the animal models. And then this is the leukemia lymphoma, same. So works in the tubes, no human studies, but there seems to be a lower incidence of the graft versus host disease after transplant. So patients with, especially with some types of leukemia, often end up getting bone marrow transplant because it's one of the best treatments we have to kind of kill off all the immune cancer cells. Prostate, same. No human study, works in tube tests. And I will tell you, I have one of the largest number of cancer patient requesting cannabis is for prostate. There's one way here, similarly to breast cancer, where this is one cancer that almost all my patients, I suggest them to try, and that is suppositories. Suppositories are very easy to apply. They don't make people high. You can take very high dose THC and CBD this way. And suppositories, outside of the fact that, yes, you're putting them up there, but honestly, it's not that difficult at all. And we use suppositories for all kinds of other things. Suppositories can be very, very expensive. We teach in our practice our patients how to make your own suppositories from the base oils that are way cheaper, saves you about 3 times the cost. Because if you buy this from dispensary, again, you're going to spend hundreds, if not thousands of dollars per month. Okay, so let's move on to potential interactions. This is very important. The main message I want to get across, if you are taking any biologic drug, so any immune modulator, in this case, it's a nivolumab, for any cancer, you have to be very careful because we're seemingly seeing worse outcomes, not just no effect, but worse outcomes. There's now 3 studies, I believe, showing that. The logic is very simple. These drugs seem to induce our immune system. So they modulate inflammatory response up. They're trying to rev up inflammation so that will kill the cancer cells. Cannabis does the reverse. It blocks the inflammatory response. You don't want to do that at the same time. You would want to take the biologic drug, see what happens. If it stops working, you stop, and that's when you can start cannabis, but you don't want to combine. What's interesting, the studies are done with the doses that are not considered doses for trying to cure anything or trying to modify cancer. They're just taking the cannabis for symptom management, whether it's pain or nausea. And even with those doses, we're seeing a significant possible interaction. I keep saying possible because there's only a couple of small studies. It's not really clear what this means. But in one study, the outcome was so significant. Patients had such a worse prognosis with cannabis that after that study, we started being very aggressive. So anybody on biologics should really probably not take the cannabis, unless, unless basically you can figure out how to target the tissue. So if you can apply the cannabis right on the tissue where the cancer is, that's a little different, because all these patients were taking cannabinoids systemic. I think local application is probably a lot safer. So let's look at our own US data. This is our best current, despite the fact that it's ancient. As I mentioned, 2006 years ago in cannabis field would consider it be like ages ago. But we still use this report because it actually, if anything, becomes strengthened by the newer data. And I'm not going to show you the newer data, but I'm just going to show you what NAS report came out. So NAS, by the way, National Academies of Sciences, is the organization that puts out this regular reports on particular health-related topics. And the way they do this, they collect the top experts. So Donald Abrams, that I mentioned, was part of that esteemed colleague of list of experts. And they would create a recommendation based on the best current evidence. It takes a few years to do this. In essence, it's the most comprehensive review that there is. And so what they said is that as of 2016, when they finished the analysis of the papers, there was a conclusive or substantial evidence that cannabis or cannabinoids are effective for treatment of pain, including pain and cancer, and then as an antiemetic for chemotherapy-induced nausea and vomiting. And that can be accomplished actually with oral, but there is also enough evidence to say that the same goes for inhaled or sublingual forms, which we'll talk about. So here I'm going to talk a little bit about something that you've never heard of, most likely, something what we sometimes describe as ECB deficiency syndrome or endocannabinoid deficiency syndrome. So the cannabis as a plant, or our endocannabinoid system as a system, tends to regulate a couple of key elements. It regulates response to trauma. It regulates pain, okay? It regulates stress adaptation or de-stressing, I would say. So like relaxation response. And it also, it also regulates appetite. So those are the four, well, it also does, to some degree, can regulate some of the sexual drive, although that's a little bit more sophisticated. We're not going to talk about that. But those four things I mentioned first seem to be the most important. So when the patients come to us, and often they're cancer patients, where they have the nausea, they are in pain, they feel their fight and flight responses are heightened. So they feel very quickly anxious or quickly agitated. They can't fall asleep easily, and then they really don't have appetite and they're losing weight. So often this falls perfectly into this idea that, look, your endogenous cannabinoid system, due to the cancer itself or the treatment of cancer, has been downturned. And we see this a lot. And those are the patients who seem to have a profound benefit from cannabis immediately. We're talking about a couple of days. We're not talking about weeks. The only caveat to this is that if you simply get a card and then you go to dispensary and you say, I have pain, give me something, you're never going to have a good answer ever for any reason, because it's very unlikely that the person in dispensary is going to sit down and spend an hour talking to you to figure out what's your whole set of problems. What are your reaction to particular medications? Have you ever taken the cannabis before? What was your response? Did you get paranoid with THC? You did not. Okay. Did you get dry mouth? Okay, you did. So maybe there's a lot of intricacy and really, really fine print that goes into figuring out how you're going to do this. Now, the good news is that you walk into dispensary, not here in Virginia, unfortunately, you're in kind of dark ages when it comes to cannabis, but that's okay. There's way out. Virginia is not perfect, but it has DC next to it. So basically every patient that works with me comes to me and who gets cannabis card ends up buying products from DC. Why? Just because choices are dramatically better. So you walk into average dispensary in Washington, DC, and you're going to see hundreds, if not thousands of products. Thousands, I'm probably, okay, I'm stretching that. No, not, but probably hundreds. Definitely, if you take into consideration tastes of particular gummies and all that and chocolates, there's going to be all kinds. And the reason for that is very simple, because it's very easy to make so. And because there are so many different products, choosing one is a nightmare if you don't know what you're doing. But on the other hand, if you do know what you're doing, it becomes a walk in the park. And then there is a critical role of something that I'm about to say. If you get anything out of, if you're not going to have someone guide you on this, and you need to know how you're going to do this. I will talk through particular symptoms, which particular products you're going to try. But the most important point is start low, go slow, and try to put it right next to where it needs to go. So those are the three critical principles. When you start low, you're doing two things to yourself. One, you're allowing your receptors to adapt to a gradual increase in the dose. That seems to get to a point where you hit the best spot. If you pass that best spot and you keep going, not only you're going to lose benefit, you're actually going to cause harm. You're potentially going to cause the symptom you're trying to treat. Such as, this is the kind of famous cannabis hyperemesis syndrome. People who recreationally use very high amount of THC to get high, pun intended here, they end up with potentially this horrible disease called hyperemesis syndrome. Basically, they vomit all day long and nobody knows what to do with this. The only treatment is to stop the cannabis. So see how it becomes kind of a very, very balanced situation. If you take low dose of cannabis, is a very powerful, maybe one of the most powerful antiemetics we have. But you take too much and it becomes proemetic. So it causes the vomiting, it causes the nausea. It's a paradox of cannabinoid system until you understand how it operates. It's very tightly regulated in our body. Our body will never make excess of particular cannabinoid for any reason under any circumstances. There's no need for that. The body regulates. And so what we're trying to do with what comes from medical cannabis plant, we're trying to mimic it. We're trying to hit that sweet spot, what we call, and the only way to get there is to start lower than where the spot is, because you don't know, everybody's so different. One patient I saw today for past 2 years has complete control of his sleep problems and his pain with 10 milligrams of taking one capsule of the full extract at night, and that works for him. Somebody else may need to take 20 twice a day. Somebody else may need to take 1 milligram 3 times a day. You just don't know. And that's the problem. And when you don't know, you always start low and you slowly titrate up. Getting it to where it needs to go. If you have a pain, and we'll talk about that again. Let's say you have a leg pain from the neuropathy, from chemotherapy. Don't start with edible. Don't start with smoking. Don't start with sublingual. Put it as a topical. And sometimes in small percent of patients, works like magic. And then there's really no side effects at all, not even close. And you're delivering much lower dose, so you're also often saving a lot of money. One of the biggest problem I'm seeing is people tend to think that if they're gonna take something like a capsule, for example, it's gonna work just as well as some other methods. Problem is, absorption and distribution of cannabis is very broad, very wide. So if you swallow something, it's going to go to the entire system and it's going to pass the liver. So you're going to have metabolism occurring, and often that metabolism is not beneficial. It can either potentiate the effect, so it can make you high but less medical benefit, or the reverse. It could just negate the effect altogether. So knowing how to take it becomes critically important. Yeah, so there are medical dispensers in Virginia. Their choices are bad, and often they have no products that I would ever recommend to patients because they either just really non-medical. So, okay, I'm gonna just for a second be a little critical because I can. I'm also going to be positive at some points towards the industry, and I'm part of that industry. So the critical aspect goes like this: these are businesses. They're not going to try to understand your medical problems. They're going to sell you what they know people come back for to buy, and what people come back to buy is the high, unfortunately, mostly. And that's every new program in every state, and Virginia is the newest out of 3, tends to go through this early phase where most of the products in dispenser are for recreational purposes. And only after, when demand is gradually growing and patients coming saying, look, I don't need any of this crap, I need medical products, then there's a gradual accommodation. Or you'll just end up with a very conscientious dispensary. Like I work with several in DC that they're just saying, I don't care what the market for recreationals, I'm going to make medical products and that's what I'm going to do. So you want to work with a dispensary like that. And often dispensary like this will have someone on the staff who knows it very well. They will understand, okay, if you have this type of cancer with these symptoms, you should be really getting this product and starting it with this dose. Most dispensaries will never have that. They will at best have someone who can tell you, okay, this particular product is good to smoke at night for sleep. That you will probably get in most dispensaries, but that's about where it goes. It doesn't tend to go further than that. Like if you ask them, well, I have these 3 problems, how should I manage all them together? That starts to get to a point where most dispensaries will say, well, I'm not sure what to tell you here. Or they will simply shine away because they start realizing that may be crossing into almost like practice of medicine. Of course, they can't do that. Right? There are a couple of states, Connecticut is the most notable one, where state requires every dispensary to have pharmacists on staff. Now, of course, that's really good, but it's also jacks up the prices dramatically, right? Because then they have to pay this pharmacist. That means that the prices of products are going to be much higher. So checks and balances. Okay, so let's talk about specific symptoms. Nausea and vomiting. I usually start either inhaled form or sublingual. If you have any lung problems or chronic lung problems like asthma, COPD, emphysema, or chronic allergies, of course, you don't want to do inhaled. If you are going to try inhale, definitely start with what's called the dry flower vaporizing. It's much safer, less cough. And often in certain products like PAX, P-A-X, and it's okay, it's not a CME, so I can mention that. And I'm not on their payroll at all. So the PAX can precisely calculate how many milligrams you're going to get. So you can dial on your phone nowadays exact dosing, and then when you're vaporizing, that's what you're getting. Most of the inhalers don't do that. They're simply kind of, you just get whatever comes. But you can figure this out on your own. Those devices tend to be a lot cheaper. Packs could be hundreds of dollars. Try combining it with ginger. Ginger is very good for nausea. Often I would tell people to kind of combine it if you're going to do a sublingual drops or even an edible for a longer lasting effect, then you would do that. Now, inhaled is the fastest acting, shortest in terms of length of action. It'll last for an hour or 2. Sublingual is about 30 minutes to start acting, maybe 20, maybe even 15, and then can last for 2 to 4 hours, depending how much you took. The oral can take an hour before it kicks in, but then it can last for 6 to 8 hours. So depending on what you're trying to do, let's say you're going to take it for sleep, you could actually end up taking oral because it's going to last you for a full night. But starting with the oral may be very problematic. If you overdose by accident, then you're going to be overdosed for 6 to 8 hours. So you have to be very careful. Again, titrate. This is in book on page 166. Okay, so appetite, big kind of issue, right? There's not a single drug that's effective. No matter what oncologists try to prescribe you, evidence is completely zero. There are some antidepressants that try. There is several other medications, but the evidence is very poor at best. The same with cannabis. Believe it or not, you look at all the studies, the benefit is mixed. but a lot of people report strong munchies, and especially strong when you do this in this particular way, when you tend to take a quick high doses. So that would be more with a high dose inhaled or sublingual, much lesser with edible.
You muted yourself. We can't hear you.
Oh, I'm gonna turn it. The woods.
You're on mute.
What did you, so I don't know where we were or what we missed, but I was muted. Sorry about that. Let me come back and say a couple more words. I repeat myself. So unfortunately, fortunately, for nausea and vomiting, we have lots of effective medications. But for chronic pain, we don't. We have opioids, we have some other medications, they're not highly effective, and almost all pain medications have a lot of side effects. So this is what I try to do. I start with 1-to-1 CBD to THC, or if you, for whatever reason, can have any THC. Let me give an example. You have cancer, you're still working for federal government. You're not going to be able to take any THC. If you're getting a card and somehow there's nothing nobody can do, you will be fired. But you can take hemp, and if you're not violating any law, so CBD and CBG is currently made from hemp. And we have a lot of people, particularly with neuropathic pain, who respond really well to this 1-to-1 mix. And that can be easily obtained on a free market. And again, if anybody's interested, you can email me, I'll give you my email, and I can give you some of the information on which companies I prefer, or we can just talk about this in Q&A when we turn off the recording. So yeah, again, this is in the book on page 178. Lots of side effects, particularly from THC. What can you do? Dry mouth, choline supplementation. Choline is a naturally occurring substance. You can get it in supplements. You can eat a lot of eggs if your cholesterol allows you to. And so that's one way. Tachycardia often responds really fast heart rate, often responds very well with an increasing dose of CBD, almost completely gets blocked, but it could be very severe side effect. A lot of people tell me that this is one of those things where, you know, I just get fast heart rate with any dose of THC. Okay, try increasing dose of CBD, because often what happens, your THC effect is not getting negated by higher dose of CBD. You can just titrate CBD without increasing THC. Unfortunately, for acute severe panic and anxiety, there's not a whole lot we can do. CBD tends to not work as an after fact. If you pre-medicate with CBD, if you know you get this, but you took high dose CBD, that will work. But once it develops, you have to just wait it out. It's a lot of reassurance. Hydration is a good idea. Dark room with soft music, and wait. I never forget, I get, well, once every 6 months on average, I get a call from our emergency room because it's another one of Dr. Coben's patients who's thinking that they're dead and they would like to get the funeral arranged right now. So I would say, yeah, just put them in a dark room and they will be undead in a couple hours and they'll go home and everything will be fine. So yeah, so when you overdose, this is when it happens a lot. When you by accident overdose, and I've had situations where very smart patients will overdose without intent, because we're all humans, we make mistakes. This particular case that's in my book is a woman who went on a long travel. She came back, she didn't take her sleep tincture with her, and it precipitated at the bottom. So when she took the sort of last, what was left, it was so concentrated that she had to go to emergency room. She just couldn't figure out where left or right was. And it could be pretty scary when you acutely, severely overdose, especially if you've never experienced this. It's not a pleasant feeling. So, okay. So some of these things are also, remember I was covering the terpenes, the smell molecules. So they can be super helpful for different side effects. this problem with memory that often happens when people will smoke particularly, or even take high dose edible, you kind of get stupid, people say, right? And in fact, it's actually true. If you're gonna try to do some kind of a task solving during that time, hopefully not driving, you're not gonna be able to do this as well, because indeed your acute your immediate memory has been suppressed, and there's good data for that. So if you have to, for whatever reason, take very high dose that's causing this, you can actually counteract it with some of this with pinene. And pinene can be now obtained as an extract. So I've sometimes would have patients have it at home, and they'll just take a couple of drops, either on a little piece of chocolate or candy, and just take it right in, or just smell it even. Just put it on a hand and smell it. And that can work quickly. Okay, so last couple of slides, I'm going to show you some cases, and then we'll get to the interesting part, which we will come back to that. So this is this is a real story. This was presented, so it's already published, so I'm not afraid of presenting all this. You can find this. This was presented at the large international integrative medicine meeting, and proceedings are published in a journal. So he came to us with a very aggressive colon cancer, stage 4. So the mass was kind of spread out already, had no distant metastasis, but nobody expected him to live for more than 12 months. The idea was to start him on chemotherapy to shrink the tumor a little bit and then try to debulk it. So remove most of it to give more life before it kind of regrows back. So he's vegetarian, high-fat, low-carb diet. He started kind of getting into how do you treat the cancer through other integrative approaches. So he read this great book called Cancer as Metabolic Disease. He's, in essence, basically, every cancer that is positive on the PET scan metabolizes sugar. So the idea, this goes back almost 100 years ago, that basically says, look, if the cancer metabolizing sugar and you completely eliminate sugar from the diet, you're actually going to have a response. And there's now a rapidly growing amount of data to say that ketogenic treatments, ketogenic diet for some cancer, like brain cancer, for example, it's already almost an adopted approach. For some other cancers, there's less so, but for example, we have a recent study showing that if you're doing fast mimicking diet for 5 days, and then you take chemotherapy, the breast cancer response is dramatically improved. In fact, even at our own cancer center, GW, we're already implementing this. So patients who are interested in this can get a consult with our nutritionist at GW to figure out how to do this practically. So this is his supplements. Again, this is all under our guidance. All of the supplements have a decent evidence. Intravenous vitamin C infusions, it's not something we're going to have time today, but there's a strong evidence of its benefit for all kinds of cancers, definitely for colon cancer. And so then he started this before he saw me. Now, let me give you a perspective of the dosing. So 1 milligram per pound of body weight is not all that much, believe it or not. But if you're taking 1-to-1 THC to CBD, and let's say he's 200 pounds, or let's say 150, I don't remember his weight. That means that you will be taking 75 milligrams of THC. If you're naive to THC, you will be in a lala zone for a long time with that dose. But if you titrate it, you quickly develop dependence, and this is by far not the highest dose I've ever seen. So people can do that. And, if you're not working, if you're not driving, you can figure out how to live with this, although I will tell you it's not easy. You can try to keep titrating CBD up, but with very high doses of THC, CBD is not going to suppress the high completely. It's going to only modify it partially. So he had several rounds of chemo, and then he went to surgery. And then I get this phone call. What happened here? We got the wrong patient. There's no cancer. It's not possible. I've been in practice for 25 years, and we don't know what happened. So, we did follow-up studies on him. We did liquid biopsy and imaging. Everything was completely negative 6 months after disease. He basically just got lost for follow-up. And then a year later, so 2 years after this, I heard that his tumor came back when he basically stopped doing everything. And then I don't know what happened. He never came back to us. So what happened with this case? We don't know. We don't know what was synergistic. We don't know what role of cannabis has played. We see cases like this in our practice all the time. Something will click with a particular patient. And then for a patient like this, we'll have a 50 who die just as fast and progress as fast as I was expecting. So the problem with cancer, generally speaking, it's such a heterogeneous disease that even in the same exact staging, in the same exact age, even if you try to apply some study, there's going to be a lot of variability, and exactly what to do is going to get really difficult to predict. But everyone who sees a lot of cancer patients seeing stories like this. And increasingly, I'm linking the stories to cannabis. Do I have a right to say that I can sort of stand to something? No, not at all, because without actual controlled trials, I don't know what any of this means. But we are seeing more and more cases. We are seeing we're starting to figure out. So for example, I mentioned the prostate. Now I'm giving almost all my prostate cancer patients suppositories. Why? Well, because the risk and side effects is very small. If they can't afford it, prostate cancer almost never ends up on biologic drugs. It's just not the type of tumor that responds to that. And some patients do really well. If you're interested, send me a message. We published a case of a long-term survivor with a prostate cancer who was using rectal cannabinoids. He was using lots of other things too. So that's the biggest problem. I don't treat ever for any reason anybody with just cannabis. I think it's just crazy. Because I would think that not only it's not going to work, chances are you're going to miss tons of other effective treatments, whether they're standard of care, chemotherapy, radiation, or there's some rather evidence integrative approaches like melatonin, for example. What are the prospects for the DA reclassifying? Not very good. Ecstasy, MDMA is going to get reclassified early in the spring first. The reason FDA have hard problem reclassifying this has nothing to do with anything in a sense. It's very strong evidence by now for certain things, for pain, the problem. Approving non-pharmaceutical is very difficult. If it's an herb, the biggest problem is not whether there's a benefit of an herb or reclassifying. The problem is that your structure of a DA approval relies on the consistency and on the reproducibility of a product. So if you can't show it, and of course, weed is called weed for a reason, and the reason is very simple: it grows like one. And when it grows like one, it gets modified like one. So each time you grow, you think the same exact variant, it's actually slightly different. And regulatory mechanism, it's very problematic for them. If you can't be precise with each batch of a product. So it's a regulatory issue, and it will be solved. Definitely not with this administration. If we get Republican administration next, probably not for another 4 years, but who knows? But there's a strong push. There's a very strong push for that. Okay, but let's finish up the slides because I have a couple other things here. So this is page 185, kind of addressing this whole question. Remember, I joked that, but this is actual quote from the book by Donald. One of the most distressing situations that oncologists increasingly face is trying to consult the patient who has a curable diagnosis, but who seeks to forego conventional cancer treatment in favor of depending on cannabis to eradicate their malignancy because of their large number of online testimonials from people claiming such results. And here's his statement. Given my long practice in San Francisco, where, a large percent of regular population uses products recreationally, I can assume that a large proportion of my patients have used cannabis during their journey. If the cannabis cured cancer, I would have a lot more survivors in my practice today. So again, it's not a precise statement, but definitely there is a logic to it. And will the cannabis ever become kind of standard of care as part of the oncology disease modifying journey? Hard to say. So this is another case. This is particularly how very effectively to use cannabis for neuropathy. And as you can see, this is a very thin person who came to us with a chronic pain, with weight loss, and just food doesn't taste good. Remember, I said that kind of endocannabinoid deficiency syndrome. This is exactly it. He was also not sleeping very well and was slightly depressed. So he wanted to vaporize. Actually, he was already smoking before he came to me. I told him, let's vaporize and let's get it more medical grade. Let's get you some CBD in the mix. And so he did very well, very quickly, So how do we look into cannabis and palliative medicine? So let's say we're no longer trying to cure someone, but we're trying to make them feel better. And this is where cannabis shines. And it shines so brightly, I would say it's the most effective tool in palliative medicine we have today. So if you're considering palliative care for whatever reason, you should be considering cannabis at exactly the same time, even before. Why? Because the evidence is so overwhelming. It's to the point where I recently published an article, a review article with one of my colleagues showing all the collective evidence that we have. But really, the most important aspect, there's no other single treatment that can treat in parallel so many different symptoms just with one. Nausea, vomiting, appetite, sleep, pain. If I were to give you a cocktail of drugs, there'll be 4, 5, 6 medications to treat that with all kinds of side effects and all kinds of problems associated with that. So this is by Dr. Agarwal, a friend of mine who contributed a little bit to the book. So, a mild euphoria, a sense of well-being in the trials is documented as a side effect, as a high. If brought about through use of cannabinoid botanical products, could very well play an important therapeutic role for patients faced with the despair of a terminal malady and the loss of function that normally accompanies. If what we consider side effect, the euphoria in the clinical trials, I'm yet to see a single patient call that a side effect. Everybody tends to say, no, that improves my quality of life. And so there's a case of a Norma who's passed a couple of years ago, was one of my most touching stories in my career. So she was seen at the very large local academic center. She was on the best breast cancer pre-treatment protocol. And yet when I first saw her, she had tremendous amount of suffering from abdominal pain, from nausea, and from not eating. And so we put her on a variety of cannabinoids and some other things. And when she passed completely comfortable. She passed many months later than she was expected to pass. And so I just want to read this from the book. I'm writing to express my immense gratitude for all you did for my beloved and precious mother for the last 6 months. She passed away last night around 7:40. Thanks to you, with all her meds, with all her cannabis, she remained pain-free and nausea-free. Later, when anxiety took over, you provided wonderful solution for that as well. At last, her long and valiant struggle has ended, and thank you for being there for her and for us, for your compassionate, timely counsel through this journey. And so they were so grateful that they started the foundation. So now some of our patients at our clinic get sponsored by their revenue. So this is the kind of a table from the journal that we published this article in. And, this is general, that's not just cancer related. There's a lot of benefit in end of life with dementia, but you can see several cancer related symptoms here, as I mentioned, right? So pain, nausea, appetite, and sleep, cancer related. So we know that it works, and the evidence is overwhelming. And in fact, often when we're talking about if patient comes to me with all these 4 conditions, I don't discuss anything before I discuss cannabis because it's so much more effective than anything else I can offer to a patient. And this is by one of the current, probably #1 researcher on cannabis, Dr. Russo, Ethan Russo, and he says the following: is there a pathway that will lead to the return of cannabis to mainstream medicine? What I didn't tell you, before 1930s, cannabis was not only standard of care in the United States of America, it was a standard part of pharmacopoeia. It was sold in every single pharmacy in the United States, and it was a top 3 sold pharmaceuticals in US. And then, of course, prohibition happens, and then one step after another, the whole process got shut down, unfortunately. But the answer is clear in as much as it has already commenced. It follows the same time-honored process that any pharmaceutical must attain to receive regulatory approval, proof of biochemical uniformity and stability, along with the safety and efficacy as proven by randomized control trials. And with that, I want to thank you, and we're going to stop recording, and we're going to turn